And now it's my great pleasure to introduce Dr. Nancy Chow. She's all the way out here from Atlanta, where she is the data and quality team lead for the CDC's Mycotic Diseases branch in the Division of Foodborne, Waterborne, and Environmental Diseases. And through her leadership, she's working on things like using whole genome sequencing and phylogenetic analysis to investigate the epidemiology of infectious disease outbreaks, and working closely with the epidemiology team there to drive understanding around methods and data management systems that can be tailored for outbreak responses. Thank you so much for joining us today, Dr. Chow.
Thank you. Hi, everyone. Well, today has been a really enjoyable meeting. I feel like we just did like a sprint through all of this. Well, thanks to the organizers for inviting CDC. As you said, at CDC, I'm within the Mycotic Diseases branch. And today I'm going to talk about the importance of One Health surveillance in responding to climate change, and specifically just give a few examples of how we're using it to track environmental impacts on fungal infections. So the first thing to note is that fungi and disease-causing fungi are inextricably linked to our environment, and that environmental changes, even small environmental changes, can have dramatic effects on which fungi emerge, where they grow, and whether they're pathogentic. And it's interesting that few fungi can grow at high temperatures, such as the human body temp. So out of the estimated millions of species of fungi that there are, it's only a few hundred that can do this. And the theory, one of the theories, is that humans have evolved to have such a high body temperature as a protective mechanism. And so if we take that one step further, especially in the context of everything that we've been talking about today with increasing temperatures, one of the questions is whether fungi will adapt faster than humans and some other animals, and will we start to see more fungi that can infect and cause disease in humans? Well, it's not just us scientists thinking about this. HBO is thinking about this. So I couldn't resist but put this slide up here. And I'm thinking that many of us, I know that Lisa has, spent several hours watching this hit show that came out earlier this year. And it's based on this very premise. It's based on a fungal infection that emerges in response to climate change. It causes a global pandemic. It also turns people into zombies and brings on an apocalypse. But so while unrealistic, it did bring a lot of attention and awareness to fungal diseases in the general public. And here you could see an op-ed written by our chief, Tom Chiller, talking about fungal diseases that we should be thinking about, especially in the context of climate and environmental impacts. And so thinking forward, when we think about how we're going to be able to have a pulse on these impacts when they're happening, how are we going to be able to track and monitor them? It's essential that we adopt a One Health approach to our surveillance systems. And of course, many of us know that One Health is this idea that we're decompartmentalizing our human, our animal, our environmental aspects of health so that we can better address health issues. And this requires collaborative, multidisciplinary efforts. And for One Health surveillance, one of the main points that I'd like to make today is that we need to build capacity for environmental surveillance and public health, because all too often, the environmental part of One Health, and in this case, environmental surveillance for One Health surveillance, is neglected. And for good reasons, because environmental surveillance is really complex. It's really hard to do. To have frequent, systematic sample collection often means that you're sampling on very large geographic scales. That often is not feasible. There's a lot of things, a lot of challenges with sample collection and testing. Metagenomics, this is a very exciting advanced molecular technology in a lot of spaces, but including environmental surveillance. And when you think about metagenomics for environmental samples, it's a lot harder than, let's say, metagenomics for clinical specimens for many reasons. But given all these challenges, I do want to tell you about two examples, fungal examples, where we're working to build environmental surveillance capacity so that we can detect climate and environmental impacts on how disease spreads, as well as antimicrobial resistance. So the first one involves aspergillosis, and we know that invasive pulmonary aspergillosis is a severe condition that it can affect immunocompromised children. And then valley fever, Desiree, you have very nicely introduced this for me, so thank you. This is a fungal disease that, based on some of our most recent surveillance data, is showing that about 10% of cases in the US are in children. So aspergillosis, it is caused, the primary causative agent is Aspergillus fumigatus, and it was classified in the critical priority group, which is the highest priority group in WHO's recently published fungal priority pathogen list. And you can see that it's right up there with Candida auris, Cryptococcus neoformans for cryptococcal meningitis, and of course, Candida albicans. And A. fumigatus was classified in this critical priority group because invasive infections can be very severe, associated with very high mortality rates. We're seeing increasing rates of drug resistance to first-line therapy, the azoles. And this development of drug resistance, there's a prominent role for the environment in this. So specifically what we're seeing is that A. fumigatus in the environment, it's exposed to azoles through fungicide use in the agricultural setting. And it's through this exposure that A. fumigatus is acquiring this, this drug resistance. And these azoles have the same mechanism of action as the azoles that we're using in the clinic. So these spores are then dispersed, they're further spread in the environment, they colonize people. And in some people, especially those that are immunocompromised, they can go on and develop these infections. And these infections are already azole resistant because we're seeing this happening in patients who are azole naive. They have no previous history of azole therapy. Now, fortunately, we're able to track this phenomenon because we can track azole-resistant A. fumigatus strains that are specifically linked to fungicide use through genetics. There's two genotypes characterized by these mutations that have been shown to be environmentally derived. So a question is, well, what's changed? Like why this is happening? Well, if we look at our agricultural fungicide use in the US over time, we can see that since the 2000s, mid 2000s, our use of fungicides have dramatically increased. And this is especially true for crops like corn, soybeans, orchard crops, but wheat is the heavy hitter. And this is a really classic example. We talked a little bit about this before too, the interconnectedness of these impacts. Because as we're seeing the geographic range of fungal pathogens expanding that can cause disease in plants, we're then seeing an increased pressure to use pesticides, including fungicides. And then we're seeing this drive, this type of resistance, antimicrobial resistance clinically. So an example of how things are interconnected. And it's not just a US issue, it's a global issue. We're seeing many countries reporting azole-resistant A. fumigatus strains that are linked to fungicide use. And actually, some of the first reports were from Europe and the Netherlands and the United Kingdom. And here you can see some work done by our colleagues in the UK, where they were conducting environmental surveillance through citizen science. And so they were able to collect a lot of samples, as you can see, like all of these little dots are sites that are sampled throughout the country looking for A. fumigatus and azole-resistant A. fumigatus. So a nice example of how citizen science, where we can conduct environmental surveillance to help track some of these impacts. Now, in terms of the US, we are starting to build our own surveillance capacity through this. And this is, I don't know if some of you have heard of CDC's AR Lab network, but through that support. And so we're adopting a regional approach. And so what's happening is that isolates that are predominantly from the West and the South, they're being sent to the Tennessee Department of Health. And then isolates from the North and the East, they're being sent to the Maryland Department of Health. And they're then tested, they're screened for azole resistance. And if then positive, they're then sequenced to characterize their genotypes. So that's just an example of some of the current capacity that we're trying to build in our country right now. Now, to end on this aspergillosis example, I did want to share one of the most recent developments in this space. So it was identified that a promising clinical antifungal that's been shown to be effective against azole-resistant aspergillosis shares the same mechanism of action with a recently authorized agricultural fungicide. And so many of us in this room, we know how long it takes to have a compound, a drug, go through clinical development. And so alorifim, this is a member of a drug class that represents a new class of antifungals, because currently, right now, we only have 3 classes of antifungals that work for invasive infections. Alorifim is in phase 2 clinical trials. It's been shown to be effective against many invasive mold infections, including aspergillosis and, excitingly, azole-resistant aspergillosis. And then we recently realized that ipflufenequin, which is an authorized agricultural fungicide, recently authorized by the EPA, shares the same mechanism of action. And so, of course, we're just now, the concern is that we're going down the same pathway that we've been going down with azoles, where we're using the same mechanism of action, antifungals, as we are using in the environment and as in the clinic. So to address this, a multidisciplinary interagency effort has happened, and this should have been happening if you would like to think about it that way, but to establish guidance, to establish some sort of risk assessment framework where that we can look at our pesticide, not just fungicide, our pesticide approval process, and systematically incorporate considerations for clinical impacts. And so the White House is very eager to see this finished. And the key players here are CDC, EPA, FDA, USDA, and others. So a nice example of that One Health multidisciplinary approach to try to really address some of these effects that we're seeing. So shifting gears to this second example with valley fever caused by coccidioides species. And again, Desiree, you've mentioned some of this, so I don't need to mention in very much detail. But cocci species, these are dimorphic fungi, meaning they have 2 forms that they switch between. So in its environmental form, cocci, it grows in the soil as a hyphae, it produces arthroconidia. And when that soil is disrupted, the arthroconidia can become airborne. And then if inhaled, cocci then converts into its host-associated form. And this can result in a symptomatic pulmonary infection and rare cases, a disseminated infection. Now, with cocci, there's a grow and bloom hypothesis that is supported by the finding that interannual variation in precipitation and temperature has been shown to correlate with seasonal anomalies that we see with valley fever. So a little bit simpler terms is that we find that cocci during very wet, increased precipitation periods that promotes the growth in this hyphae form, producing arthroconidia. And if those wet periods are then followed by very dry, dusty drought periods, that one provides opportunities for cocci to survive because it then outcompetes its microbial neighbors that maybe can't survive in such high temperatures. But 2, it provides opportunities for the arthroconidia to be aerosolized. And so that, in combination with the extreme climate events that of everything that we've been talking about, this is leading ultimately to more people who are at risk for valley fever. And if we look at the data, this is what we're seeing when we look at this endemic range for valley fever, when we look at the geographic range for endemicity. And so here you're looking at maps from the 1950s that are based on skin testing, environmental data, and you can see that cocci, it's primarily in the southwestern United States. And if you look at current maps, it's pretty much the same, but we're starting to see that trickling northward, where we've seen it identified in the soil as far north as Washington State. And I don't need to say anything on this because we've already seen what the models are predicting. But just to say that these are what the models are predicting. So how do we monitor this in reality and not just through studies that happen every once in a while? How do we monitor this in near real time and taking advantage of the systems that we have? Well, one of the things that we've been trying to do is build environmental surveillance capacity for cocci via air sampling. And we've done some really great work with the Arizona Department of Health, as well as the California Department of Health and other partners through an initiative called Cocci Watch. And so you can see here, this is some of the capacity that we've been trying to build up, where we've been using these high volume air samplers, placing them throughout cities, and then using these filters that are capturing the arthroconidia. You can see the thousands. I mean, it's just incredible the amount of volumes of filters that need to be tested. And a lot of this work was done pre-pandemic and needed to be paused because public health departments just didn't have the bandwidth to continue this. And so we're just now starting to talk about what this looks like, resuming these efforts. But if we look at the preliminary data, we see a few things. One, this is possible. Cocci air sampling by molecular detection is possible. So if you look at the figure below in Phoenix, you can see that when we're looking at cocci prevalence in the air for these sites that we've sampled, we see a distribution, so from low to high. So that's good to see. Then, if the other thing is that we see that there's a high variance in prevalence in cocci prevalence by space and time. So this other figure, this big one here on the right, if you're looking at this on the y-axis, we're looking at different sampling sites. On the X, we're looking over time. And these bars represent specific sampling events. And the redder you are, the more cocci you have. And you can see that at certain sites, we see a change in the prevalence where we can detect hotspots. And theoretically, these hotspots indicate times, they indicate spatial points where people in the vicinity are at higher risk for cocci exposure. And so all preliminary, but laying the foundation that potentially we could have near real-time air monitoring for cocci. So that's the goal of this work. So in summary, I'll say that One Health surveillance can help us track climate and environmental impacts on infectious diseases. And for this, environmental surveillance that's built into our public health infrastructure is critical. We've talked about two examples, azole-resistant A. fumigatus and valley fever, where we're seeing the effects of climate and environmental impacts and how we're trying to build environmental surveillance capacity so that we can respond to these. But I know that with the summary slide, that's usually the end of it, but I've got two more slides. So bear with me, but I have 3 minutes here. I did want to zoom out just very briefly and say what CDC as a whole is doing in response to climate change. So a few years back, we created a task force called the Climate and Health Task Force. And this comprised over 100 representatives across the agency from various different programs. And the goal of this was to develop a strategic framework that was going to guide climate and health activities that we're doing in the agency, as well as in coordination with our partners. And David, I would very much appreciate if you asked me about CDC funding, but up to you. So, in terms of the strategic framework structure, the vision that we have is to be a nation prepared to respond to the public health threats of climate change at home and abroad. And the key focus areas that we've established, and the idea is all of the activities, all of the climate and health activities that we're doing as an agency and with our partners, it should align to these 5 key focus areas. And it's several things. It's to make sure that we're systematically addressing health inequities, environmental justices, to modernize our public health data and IT infrastructure for the surveillance that we're doing and the forecasting that we're doing, to produce scientific evidence and evidence-based guidance so that we have informed public health decisions and interventions, that we're preparing communities to be ready to respond to these health changes as part of climate change. And then lastly, that we're educating and equipping key audiences, whether it's healthcare workers or employers, to be able to be informed for how to adapt to these changes. So that's just a little bit of what CDC is trying to align and provide that North Star to our activities. And so I am at time, and I will stop there.